Good morning, everyone, and welcome to this morning's academic meeting, which is hosted by the Division of Dermatology. So today's speaker is Dr. Michelle Hawkins. Michelle is a registrar at the Department of Dermatology at the University of the Witwatersrand and is currently rotating at Charlotte Mateke Johannesburg Academic Hospital. She completed her undergraduate studies at WITS and also holds a diploma in HIV management and a postgraduate diploma in allergology. Michelle will take us through an approach to cutaneous T-cell lymphoma.
Good morning, everyone. Thank you for the opportunity to speak today. It is my pleasure to give this overview on the topic of cutaneous T-cell lymphoma. So firstly, what is a lymphoma? Sorry, the slide's moving. Lymphoma is a cancer of the lymphocytes, which are immune cells that can mutate and undergo uncontrolled proliferation. This gives rise to two main types of lymphoma, which are the B and C and T-cell lymphomas. We'll be talking about the most common cutaneous lymphoma, which is the T-cell lymphoma, which makes up 80% of skin lymphomas. Cutaneous T-cell lymphoma is a broad group of over 100 lymphoproliferative disorders that includes mycosis fungoides and Sezary syndrome, CD30 positive lymphoproliferative disorders, and many other rare variants of cutaneous T-cell lymphoma that make up about 5 to 10% of cases. We'll be talking about the most common ones, that is mycosis fungoides and Sezary syndrome, which together make up 65% of cutaneous T-cell lymphomas. These are particularly difficult to diagnose because they tend to appear like common rashes and may take years to fully declare themselves on investigations. Let's turn our attention to mycosis fungoides, the most common cutaneous T-cell lymphoma. Mycosis fungoides occurs when there's a cancerous transformation of the T helper lymphocytes in the skin. It's characterized by a very indolent, slow progressing course from patch stage to plaque stage, most commonly, that can look like eczematous or psoriatic plaques and that are distributed in the bathing suit area, the old-fashioned bathing suit. Less commonly, they may progress to tumors and erythroderma, although these can also be presenting features from the start. Visceral disease is only found in 1% of patients at diagnosis, but it can and does occur. And if it does, it's likely to spread to the lymph nodes, the spleen, liver, and the lungs. This 33-year-old female patient presented with a 4-year history of an itchy rash, which showed the classic combination of patches, plaques, and tumors on the trunk and the proximal limbs. You can see these hyperpigmented patches that are distributed on the neck and chest. She has some scaly annular plaques on the leg and tumors on the flank. If it isn't clear yet, MF is not related to any fungus, it's a lymphoma, but it can tend to look like mushrooms or tinea, and hence the name it was given when it was first discovered. Her biopsy showed a dense population of atypical lymphocytes in the dermis with cerebriform nuclei, and you can see a depiction in this picture. The nuclei tend to look like a brain, and hence it's called cerebriform nuclei, and she also had large cells. Her immunohistochemistry showed CD3 and CD4 positive, which are markers on T cells, and CD8 positive. They were CD20 negative, so they were not B cells, and they were CD30 positive, which is not typically observed in MF, but CD30 markers may appear on large cells that have transformed to a higher grade lymphoma. So we diagnosed her with mycosis fungoides with CD30 positive large cell transformation. We treated her with methotrexate based on its response rate, on its response rate of 58% in tumor stage patients, and biweekly narrowband UVB radiation and ultrapotent topical steroids. Initially, this patient presented with a few hyperpigmented patches and plaques in a bathing suit distribution, and it's important to quantify these lesions for the purposes of staging and treatments. We stage the disease according to the TNMB classification, where T stands for the amount of skin involvement from less than 10% or more than 10% of patches and plaques to tumors and erythroderma. N is for the lymph node involvement, physically and histologically. M is for visceral involvement, and B is for the presence of atypical lymphocytes, otherwise known as Sezary cells, that are found in the blood. The TNMB stage has a corresponding clinical stage 1A to 4B that guides the prognosis and management. This patient had skin involvement of less than 10%, which initially made her a T1 patient, but she later developed a tumor, which is T3 disease, with palpable lymph nodes, but no histological nodal involvement or visceral or blood involvement, which makes her a T3 NXM0B0 stage, therefore stage 2B, that is advanced disease. The development from patch or plaque stage disease to tumor disease drops her 5-year survival down from 98% to 56%. Her histology showed a severe lymphocytic infiltrate with irregular nuclear contours, and you can see an example in the picture of a lymphocyte with irregular nuclear contours. Together, the clinical and immunohistochemistry picture led to a diagnosis of tumor stage Mycosis fungoides, and despite negative T-cell gene rearrangement studies showing a polyclonal population. She was being treated with ultrapotent topical steroids and biweekly phototherapy. But after the tumor developed, we escalated treatment to total skin electron beam therapy and low-dose methotrexate. This brings me to a further discussion on Mycosis fungoides. In terms of pathogenesis of the disease, the events leading to the development of malignant T cells are still unknown. Some speculate that it's caused by chronic exposure to antigen that leads to uncontrolled clonal expansion, but the nature of the antigen is yet to be proven. Some possible causes we think are viruses, bacteria, dermatophyte infection, and hydrochlorothiazides. It develops from a background of chronic inflammation and accumulation of genetic mutations. The pattern in early MF is a more Th1-like. The non-cancerous CD8 lymphocytes suppress the malignant clone. And in more advanced disease, a Th2 environment exists and allows the malignant clone to proliferate. Patients die from sepsis due to immune system failure. Lastly, studies report some aberrant alterations on specific chromosomes. MF is typically more predominant in males with a ratio of 2:1 with females, and in Black patients where it tends to present at an earlier age and more severe in its stage. The incidence is increasing. The prevalent peaks at 55 years old, but it can also present in children and adolescents, like this patient. He is a 19-year-old male who presented with an itchy rash since he was 9 years old. He had been treated as atopic eczema with emollients at local clinics. A review of 616 childhood MF cases found that pediatric MF accounts for about 5% of total cases. It found that juvenile onset MF has a comparatively good prognosis, although recurrences are frequent, which warrants long-term maintenance and follow-up. On examination, you can see these thick, scaly plaques distributed widely. There's a background of hypopigmented patches on his cheeks and hyperpigmented patches on the back. You can also see some scattered nodules and some tumors on the trunk. And there are some annular tumors on the dorsal hands. On further examination, the patient also had a significant lymphadenopathy, but no hepatosplenomegaly. The workup of any MF patient requires a combination of multiple factors. Firstly, a clinical presentation that is consistent with cutaneous T-cell lymphoma. Skin punch biopsy must be taken to look for the classic histological features, as well as immunophenotyping and T-cell gene rearrangements. As MF may take several years to become histologically diagnostic, biopsy may need to be repeated over time. Bloods should be done for FBC and DIFs to look for atypical lymphocytes. LDH is a non-specific marker of tumor burden that's associated with a poor prognosis. And of note, only enlarged lymph nodes require biopsy and subsequent imaging of the organs via PET scan preferably or CT scan. Bone marrow biopsy is not indicated in the workup and staging of MF except in select circumstances like bone marrow transplant workup, but it may be performed in Sezary syndrome. On immunohistochemistry staining, MF cells are typically CD3 and CD4 positive and sometimes CD8 positive, but they lose their CD7 and CD26 antigens. The CD4 to CD8 ratio increases as MF worsens, and CD30 positivity indicates large cell transformation which has a worse prognosis. Lastly, gene rearrangement analysis is performed in equivocal cases to detect clonal T cells. That's when the cancerous T lymphocytes form a large population of clones. The histology that's classic in MF will show epidermotropism of lymphocytes. That's when the lymphocytes move up to the epidermis. The lymphocytes are larger, darker, and have a more angulated or cerebriform nucleus. There are lymphocytes with halos, and they form collections called portreomicroabscesses. And then a dense sheet of lymphocytes can be seen obscuring the superficial and deep dermis. Our patient displayed all of these features, as you can see in this example of his histology. But in addition, the lymphocytes were found to be in keeping with a large cell transformation. That is, the CD30 lymphocytes were over 4 times their normal size, and they comprised over 25% of the overall infiltrate. On his immunohistochemistry, most neoplastic cells were CD4 positive and some CD8 positive, and they were indeed CD7 and CD30 negative. So this is suggestive of a Mycosis fungoides with CD30 negative large cell transformation. PCR testing was positive for clonal cells in the biopsy. In this patient, bloods showed a raised LDH, but were otherwise all normal. There was no blood, lymph node, or bone marrow involvement. Our patient is a T3-NXM0B0 stage, which makes him clinical stage 2, advanced disease. According to the stage and our accessibility to treatment, we administered bi-weekly narrowband UVB sessions whilst awaiting an appointment for total skin electron beam therapy. We prescribed methotrexate 10 milligrams weekly and ultrapotent topical corticosteroids as an adjuvant treatment. We were pleased to achieve a remarkable response in just 7 weeks. And you can see the before and after pictures from the 1st week to the 7th week. The poor prognostic factors in MF include advanced clinical stage, being male, having an advanced age and therefore less ability to mount an adequate immune response against the disease, having a raised LDH, large cell transformation, especially if it's CD30 positive, and having a clonal population, as well as follicular tropism, which is when the cancerous lymphocytes invade the hair follicles, which are at a deeper level. In this patient, you can see an example of follicular tropism on the face, where you can see what we call a leonine facies, which is supposed to look like a lion's face. Oops, sorry. This male patient also has leonine facies. Both of these patients were found to have advanced disease and lymph node involvement, so they were started on chemotherapy. Now let's move on to Sezary syndrome, which is characterized by a triad of erythroderma, which is red scaly skin that covers over 90% of the body surface area, lymphadenopathy, and abnormal cerebral lymphocytes, in other words, Sezary cells that can be found in the blood and lymph nodes. While Sezary syndrome is usually described as a leukemic phase of MF, its more recent studies have actually revealed that there are major genetic and phenotypical differences in the two diseases. Therefore, it suggests that they should be considered 2 different types of lymphoma. Sezary syndrome presents exclusively in adults, usually around the age of 60 to 65, and it's an aggressive disease with a poor prognosis. Criteria for the diagnosis of Sezary syndrome include having a Sezary cell count of over 1,000 microliters. The CD4 to CD8 ratio must be raised above 10, and there should be a demonstration of a T cell clone in the blood. Patients present with a typical fiery red, scaly skin that has some lichenification, and it's usually associated with a leonine facies, alopecia, hyperkeratosis, or thickening of the skin on the palms and the soles. Patients with MF may progress to Sezary syndrome, but patients with Sezary syndrome are usually erythrodermic from the onset. It's important to note that erythroderma can be caused by multiple different diseases, such as eczema, psoriasis, seborrheic dermatitis, and drug eruptions. Histologically and on immunohistochemistry, there are no reproducible differences between MF and Sezary syndrome, but Sezary syndrome biopsy results tend to be non-specific and just showing spongiotic dermatitis. This patient presented with erythroderma of 4 months and intense pruritus and chills with no previous history of having had a rash. On examination, you can appreciate this generalized erythematous scaly skin with lichenification and palmoplantar keratosis. He also had significant lymphadenopathy. Biopsy results showed a spongiotic dermatitis in keeping with eczema. But because of his profile and poor response to topical treatment, we had a clinical suspicion to investigate further. Bloods revealed a Sezary cell count of 3,000 and a raised CD4 to CD8 ratio of 11. Lymph node biopsies showed histological involvement. So we referred him to hem-oncology for further management. When it comes to the management of cutaneous T-cell lymphoma, treatment is facility dependent, and we use a combination of topical and systemic treatments. The cutaneous lymphoma tumor group developed a European consensus of the treatment of mycosis and fungoides and Sezary syndrome by stage. And you can see this table of first and second line treatment with their levels of evidence next to them. Early stage mycosis fungoides patients can do well with skin-directed therapy like topical steroids and narrowband UVB or PUVA. Chemo should be avoided in the aim to cure early MF because it has inferior results and a severe side effect profile that results in a shorter lifespan than other options. Tumor stage patients are recommended oral retinoids like bixarotene, acitretin, and even isotretinoin. Similarly, total skin electron beam therapy is an excellent choice as it shows an overall response rate of 95% and a complete response rate of 45%. Low-dose methotrexate is another good option. Patients with erythrodermic MF also do well on oral retinoids, total skin electron beam therapy, and low-dose methotrexate. But if you have a patient with lymph node or visceral involvement, then at that stage, you would have to consider systemic therapies like multi-agent or CHOP chemotherapy, biologics, or even allogenic stem cell transplant. Alternatively, there are newer biological therapies such as brentuximab vedotin, which is a CD30 inhibitor best used in the treatment of CD30 positive MF. Although unfortunately, we don't have access to these biologicals in our public system. Sezary syndrome, on the other hand, is very difficult to treat and has a 5-year survival of about 25%. Ideally, photophoresis in combination with other systemic treatments is recommended. Photophoresis involves removal of the blood IV, separating the white blood cells from the red blood cells via centrifugation, and irradiating the white blood cells with UVA, and then returning the treated cells back to the patient. This used in combination with other agents like oral retinoids or methotrexate or chemotherapy is effective in some patients, but the median survival time is still only 39 to 60 months. Total skin electron beam therapy has some complete cutaneous response, as well as improvement in the blood burden of malignant cells. And low-dose methotrexate has a reasonable response rate of about 50%. As a second-line option for Sezary syndrome, one can consider biological therapies, chemotherapy, or allogenic stem cell transplant. In conclusion, cutaneous T-cell lymphoma consists of a broad group of lymphoproliferative disorders, the most common being mycosis fungoides and Sezary syndrome. Mycosis fungoides classically presents as patches, plaques, and tumors, and Sezary syndrome presents as erythroderma. But they can be mistaken for common skin rashes, and it's important to be able to recognize them. Mycosis fungoides and Sezary syndrome can be difficult to diagnose, so diagnosis requires an index of suspicion and long-term follow-up. Lastly, treatment is combined, and it depends on the facility that you're working from. Please see my references, and thank you for your time. I'd like to thank our host, Janssen, who've generously sponsored us with breakfast. If you wouldn't mind, they'd like to say a few words on the novel treatments that are available in South Africa.